One thing I struggle with is in my newly diagnosed patient, do I send a focused set of tests to perhaps more quickly get a few results back, like EGFR, ALK, or ROS? Or do I send a broad panel that gives me the EGFR sequence plus a range of other rarer variants? Our current practice at Dana-Farber is somewhere in the middle. We send a quick ALK and ROS IHC. Those IHC tests are well done by our pathologists, at least, to find ALK and ROS cases. And then for sequencing, we do a broad panel that gives us EGFR, KRAS, BRAF, MET, HER2, rearrangements, and a range of tumor suppressors and other rare variants. And what that gives us is, with about the same amount of time, about the same amount of specimen, and about the same cost, it's a relatively similar cost at this point, we get a huge range of variants instead of just a focal variant. And with the newer variants coming along and the greater range of targeted therapies, we increasingly feel that panel-based testing is a way to create the most treatment options for our patients.
Currently, larger panels, which I define as either a clinical whole exome or even 300 to 400 gene panels, are often used for patients with refractory solid tumors or lung cancer for which we're looking for a driver mutation. So oftentimes in a never smoker in particular who's had sequencing done. I actually just had a patient today that had standard of care testing done with smaller PCR-based panels, EGFR, ALK, ROS1, and those were negative. And upon testing with a broader 400 gene panel, a driver mutation was detected. And so typically for the right clinical context, a broader panel is favored. Tissue-based approaches often can have 300, 400, or even clinical exome now, which allows us to survey the entirety of the cancer genome. And liquid biopsy approaches such as cell-free DNA now let us query almost 75 genes. And so I think between the tumor-based methods, which test more genes, and liquid biopsy-based methods would help us in patients for which they have difficult to access tumors because of where their cancer is located, or for patients who develop resistance to targeted therapy. I think liquid biopsies are particularly important in that setting. One of the ways we utilize whole exome sequencing in an academic medical center is actually for cell therapy-based approaches. If we're trying to determine which specific T cell population to amplify for what we call TIL therapy, or tumor-infiltrating lymphocyte therapy, we need both the exome to look at all the mutations that the cancer has, as well as to find the patient's HLA type, so we can engineer a specific cellular product for that specific patient. So I think beyond that unique clinical context, or a patient who's a never smoker, who has non-small cell lung cancer for which even a 400 gene panel did not detect a driver mutation, I think these are two scenarios in which we may consider a whole exome-based sequencing strategy, which typically is done in academic medical centers and likely not currently of immediate use in a community setting, at least at the current time. However, the 300 to 400 gene tumor-based NGS panels, I think in particular, are likely to be beneficial even in the community setting. And the liquid biopsy approaches for which we have 60 to 70, 70 plus gene panels, I think may be of utility also in the community setting as well as in the academic setting as well.
NCCN guidelines now suggest panel testing as the most thorough way of getting genomic testing for lung cancer in order to create the most number of options for our patients. It's the most complete approach to create targeted therapy options and improve treatment outcomes. And so if there are NGS panels available for you, if you can get them reimbursed, we often can. If you have enough tissue for it, I think reach for an NGS test as an alternative to a standard EGFR test on its own.